join me in welcoming Dr. Aseem Malhotra.
Thank you, Danielle. I'm delighted to be here. It's good to be amongst like-minded people in the College of Naturopathic Medicine that really understand that food is medicine. So this talk isn't about food being medicine, though. This is really to try and understand the roots of our healthcare system problems and healthcare system failure. And you know, my late father taught me, and I think most of us probably would agree with this, that the ultimate purpose of knowledge is to reduce human suffering and to achieve a more stable, sustained, authentic level of happiness. So if that's what most of us are trying to aim for, why are we not getting it? What's actually going on? And hopefully I'll give you some insight into that from my perspective in the talk. So yeah, very briefly, I'm a practicing cardiologist. I qualified from medical school in 2001, so I've been a qualified doctor for well over 20 years. And in that time, most of my work has been in the NHS and probably managed about 20,000 patients in my career. And of course, you know, my clinical experience certainly informs me to have a better understanding of why we are not achieving the best for our patients. Okay, so the title of the talk is Revolutionizing Health Through Real Evidence-Based Medicine. So I'm going to ask a question rhetorically. What's worse than ignorance? The illusion of knowledge. Right? So the late great Stephen Hawking, the greatest enemy of knowledge is not ignorance, it is the illusion of knowledge. And I think it's important also to be precise in some of the things we talk about in terms of definition. So I love this definition that the World Health Organization put out. And listen, I know the World Health Organization doesn't do everything right, but you know, this is certainly one thing that I think most people would agree with. I like health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And then what about public health? I'm known as a public health campaigner. I do have a role as the president of the scientific advisory committee of a charity called the Public Health Collaboration. So it's also important that we understand what public health is about, because it does affect all of us. So there's a couple of definitions which I really like. The science and art of promoting health, preventing disease, and prolonging life through organized efforts of society. And another definition, which is very good, is public health is the science and art of organized societal efforts to ensure and create the conditions for the highest possible level of health and well-being of populations consistent with the values of social justice and human rights. And this definition, I think, will become much more relevant as the talk goes on. But we've got a major healthcare crisis. So certainly in the UK, we've had a stalling of life expectancy since 2010. And I think what's even worse is that now we are seeing that unhealthy lifespan is increasing. So people are living less years in good health. And the question is why? So if we go down to the level of the doctor and patient to start with, there's a very nice, elegant, analytical framework for teaching and practicing medicine. And that was first put forward actually over 25 years ago. And it's called the Evidence-Based Medicine Triad. And I really like this because I think it isn't just a useful framework to understand how we can get the best outcome for our patients. But actually, I was thinking about this a bit more philosophically. I think in some ways, this framework is also useful for all of us to understand how we can all achieve the best possible mental and physical health for ourselves and also for the community. So what does it involve? Well, we take our individual clinical expertise, the best available evidence, and last but not least is also taking into consideration individual patient preferences and values for the purpose of improving patient outcomes. And specifically, what does that mean? Well, it means relief suffering, treating illness, managing risks. But if there is a problem with the best available evidence and we're not taking into consideration patient preferences and values, we are either going to get suboptimal outcomes or even worse, do harm to patients. And unfortunately, evidence-based medicine has become an illusion. Evidence-based medicine has been hijacked by vested interests. And what we have now, sadly, and I would describe this as a pandemic of misinformed doctors and misinformed and unwittingly harmed patients, based upon a number of factors, which are biased funding of research. So that's research that's funded because it's likely to be profitable, not beneficial for patients. Biased reporting in medical journals, biased patient pamphlets, biased reporting in the media, commercial conflicts of interest, defensive medicine, and last but not least, medical curricula that fail to teach doctors how to understand and communicate health statistics. So these are really at the roots of the problem. How big is this? Is it a small issue with evidence-based medicine, or is it a big issue? So most healthcare professionals are actually unaware of the poor quality and biased research that leads to overuse of medications, underuse of more effective, safer alternatives, or even cheaper medicines, avoidable adverse events, missed opportunities for treating the right patient at the right time with the right treatment, and also huge waste in the system. And why is that? Well, John Ioannidis, who's a lead author on this paper, just to give you some background on John Ioannidis, I would call him a Stephen Hawking-like figure of medicine. He's the most published, cited medical scientist in the world. He's a professor of medicine at Stanford in epidemiology. He has no financial conflicts of interest. He is a very, very, very smart guy, and he's able to look at research papers and take them apart and try and determine the reliability of research. So he wrote this paper, and I recommend, afterwards, this is definitely part of your reading material because it's not a long paper and it's very, very good, very comprehensive. I think it was published in 2017. It's called How to Survive the Medical Misinformation Mess. So on those issues I've already discussed, these are the four major problems he describes in what drives medical misinformation. So he says much published research is not reliable, offers no benefit to patients, or is not useful to decision makers. Most healthcare professionals are not aware of this problem. Don't presume your doctor knows about this. They also then lack the necessary skills to evaluate the reliability and usefulness of medical science. And then patients and families frequently lack relevant, accurate medical evidence and skilled guidance at the time of medical decision making. So we're all vulnerable to this misinformation, everybody. Whether it's policymakers, whether it's doctors, whether it's scientists, whether it's Joe Public, we're all vulnerable to this. It's all of our problem, essentially. And this is also something I've learned in my career as a campaigner and activist, and I've spoken to very senior people at health policy level, to politicians, you name it. I've had those conversations around, in closed doors or giving presentations. And this isn't a criticism. It's just that we're all vulnerable, essentially. And I'm going to go to the roots of it. Don't worry, I'll get there to why this is, to this medical misinformation. And John Ioannidis in his paper says ignorance of this problem, even at the highest levels of academic and clinical leadership, is profound. One of the other interesting things, he wrote another paper a few years earlier, which is probably a little bit more concerning, which was entitled Why Most Published Research Findings Are False. But one of the factors he cites in his mathematical modeling, because he's also a mathematician, I think in Greece, when he got like the prize of his university as being the smartest guy in mathematics. I mean, he's a very, very clever guy. And one of the things he cites as a risk factor for medical misinformation is this. He says, the greater the financial and other interests and prejudices in a scientific field, the less likely the research findings are to be true. Now, think about that right now with what's happening. Does that ring any bells with anything else that's going on at the moment? Hint, hint. Okay, and then, so I think we just need to take a step back, and I think most people don't fully acknowledge this, is that when we think about the drivers of medical misinformation, of course, at the root of it is the drug industry in many ways, because they're the ones that synthesize or they conduct trials, and doctors make their clinical decisions based upon industry-sponsored trials predominantly. But I think there's a few truths that people need to fully embed into their psyche. So, pharmaceutical companies and medical device companies have a legal obligation to make profit for shareholders by selling their product, but they are not required. This is really important for people to understand. They are not legally required to give you the best treatment, although most people would like that to be the case. But the real scandals are these. The regulators, medical regulators, fail to prevent misconduct by industry, and that doctors, institutions, and journals that have responsibilities to patients and scientific integrity collude with industry for financial gain. And I became aware of this problem many, many years ago. I mean, I've campaigned a lot on the issues of obesity and lifestyle. We know that chronic disease driven by lifestyle is a huge factor. But the twin evil, if you like, is the fact that we've also got this over-medicated society. And once I became enlightened and aware of this, then, and also I think it's important to understand, just to give you some headline figures, why this is also a big issue. One estimate from a very reliable scientist, the co-founder of the Cochrane collaboration, Peter Gosha, suggests that the third most common cause of death after heart disease and cancer is prescribed medications, what your doctor prescribes to you because of side effects. I mean, that's pretty shocking. And you know, and also, it's also been analyzed that most of those adverse events were avoidable if there was just better transparency. So I was in the European Parliament in 2018. I've attempted on at least 3 occasions through mainstream media with very credible, eminent doctors and scientists to call actually for an inquiry into the way that the drug industry works and the fact that they have so much power to try and reform the system. And unfortunately, that hasn't happened. And I've tried, you know, I've done it through the BBC, through The Guardian, through the Daily Mail. Dare I mention the Daily Mail? That supported all this. So there is a bit of awareness, but with anything like these, campaigns need sustainability. And maybe that's one of the reasons it wasn't successful. But I took it to the European Parliament, and I said in the European Parliament, I said, this, you know, because of this bias funding, because of the commercial corruption, honest doctors can no longer practice honest medicine. And that is actually, again, a big problem. So what else is happening in terms of why do we have this healthcare system failure? Because those powerful entities that are at the root of this problem haven't been reformed, and even though there is a wealth of evidence of fraud being committed, I'm not going to name any drug company obviously, but most of the top 10 drug companies have been found guilty of committing fraud. So between 2009 and 2014, most of those companies combined paid fines of around $13 billion for illegal marketing of drugs, hiding data on harms. And what Peter Gosha points out in this BMJ article, he says that there's no disincentive for them to not continue in that manner. For them, it's a cost of business. Nobody, when those frauds were committed, I'm going to give you one very egregious example shortly. Nobody got fired. Nobody lost their job. There is legal protections, if you like, for people within those companies, and the company itself may get fined, but those people who are involved in those fraudulent activities are protected. So what he suggests, and I'll read it to you as well, he says, it is time to introduce tougher sanctions as the number of crimes, not the detection rate, seem to be increasing, and there is evidence of increasing as well, crimes in this area. Fines need to be so large that companies risk going bankrupt. And top executives should be held personally accountable, so they would need to think of the risk of imprisonment when they consider performing or acquiescing in these crimes. And I think he has a very important point. I think he may raise an important point. I would certainly agree with that, considering what we know what's been really happening over the last couple of decades. Okay, well, you might stop for a second and say, hold on, Dr. Malhotra, but hold on, what about these life-saving drugs and innovation and all that kind of thing? Well, yeah, it's a fair point. So let's look at the totality of evidence around that. Certainly in the last couple of decades, and this is actually data specifically looking at drugs that were, you know, almost 1,000 drugs that were approved in France, and looking at the outcome of the effectiveness of these drugs that were approved by the regulator in France between 2000 and, say, 2010. And what they found was most of the drugs were copies of old ones. So these are drugs that are produced, molecules are changed here and there, they patent them, they make so much money. By the way, and the taxpayer, we're the people that pay for it. Okay? So they're basically copies of old ones, most of them. And they found in France that more drugs, 15.6% of the drugs that were approved, were found to be more harmful than beneficial. And when it came to actual drugs that were of true innovative value, it was about 8%. So you've produced double the amount of drugs that have been approved by the regulator, have proven to be more harmful than beneficial compared to the ones that are, say, a therapeutic gain on previous drugs. What do we conclude from that? What's the headline from it? Without a shadow of a doubt, I'm very happy to debate this with anybody, and this, by the way, is replicated across the world, the overall impact on society of the pharmaceutical industry in the last couple of decades has been a negative one. Very happy for anyone to debate that with me later on, but I can't see how that is not a clear headline. Okay? This is what this industry are doing to society. Marcia Angel, former editor of the New England Journal of Medicine, the highest impact medical journal in the world. In fact, she said this a few years ago. She did her own analysis in America, and she found of the 667 new drugs approved by the FDA between 2000 and 2008, only 11% of them were truly innovative. 75% were essentially copies of old ones, And then one of the reasons for this system failure is that drug companies spend twice as much on marketing than they do on research and development, but specifically 20 times more on marketing than they do on researching new molecular entities. So the system encourages this kind of behavior, basically. What else does she say? It is no longer possible. This is the former editor of the New England Journal of Medicine, the highest impact medical journal in the world. It is no longer possible to trust much of the clinical research that's published or to rely on the judgment of trusted physicians or authoritative medical guidelines. I take no pleasure in this conclusion, which I reached slowly and reluctantly over my 2 decades as an editor of the New England Journal of Medicine. Is she alone? No. Richard Horton, in an editorial he wrote, and you can look this up online, in 2015, he was referring to a meeting that he went organized by the Wellcome Trust. It was Chatham House rules in terms of who was there, but he said some of the top medical scientists in the world were there, and in this editorial he wrote, possibly half of the published literature may simply be untrue. Richard Smith, the former editor of the British Medical Journal, now the BMJ, he also wrote in the BMJ about a meeting he attended with lots of senior academics, and he was giving a lecture, and he was talking about research misconduct basically going on in British institutions, and this is about British institutions. And he asked the audience, how many of you know of a colleague that has committed fraud or has, misrepresented results in your institution? A third of them put their hand up. He said, how many of you reported it? They all put their hand down. So probably around 2012, 2013, I started my own enlightenment in this area as a jobbing doctor, as a cardiologist. And one of the things that drove me down this path was the fact that I was seeing increasingly over a 10-year period since I'd qualified, that the patients coming in weren't getting better, they were more physically sick, they were more miserable, and it was putting a lot of stress on the system, working in a busy NHS hospital. And I could see what the pattern, and the reason I went down the pattern certainly of trying to be an advocate to tackle obesity, but also over-medication, is I saw then 10 years ago that if we don't tackle this, our NHS is going to be broken. This is 10 years ago. I realized that, like probably I'm sure a lot of other people, but then thought, well, I'm going to do my bit to try and solve that problem. And in that journey as well, through my publications and meeting people and doing private advocacy and going to not just making noise, but meeting policymakers, I also worked with the Medical Royal Colleges, essentially the organization that represent every doctor in the UK, called the Academy, and I spent a year working with them doing various projects. And one of the things is I convinced them, I sat around a table with all the Royal College presidents, Royal College of Physicians, Royal College of Surgeons, Royal College of General Practitioners, and it didn't take much to convince them that too much medicine was a major public health threat. And I wrote this paper, it was a coordinated campaign between the Medical Royal Colleges and the BMJ that started this Too Much Medicine campaign called Choosing Wisely. And it was the initiative, and I was the lead author. And two of the co-authors, are very, very good, eminent people. One was the chair of the Medical Royal Colleges at the time, Professor Dame Sue Bailey, who was a psychiatrist. And the other person who was the chair, but then at that stage moved on, was the chair of the GMC, okay? General Medical Council. So these are people in eminent positions who wanted. I honestly believe most doctors want to do the right thing, and the evidence was so strong that they thought actually we need to campaign on this issue. So I wrote this paper. It got a lot of attention in the media at the time, BBC. I was talking to Susanna Reid and on Good Morning Britain about it. And then one of the things, coming back a bit more to the science, if you like, or the health policy side of stuff, people to think about, is one of the comments that the Medical Royal College has made about waste is that doctors have an ethical responsibility to reduce the wasted use of clinical resources, because in a healthcare system with finite resources, one doctor's waste is another patient's delay. So if we're doing lots of stuff which doesn't have a good evidence base behind it for commercial reasons, and we're spending lots of time and energy in a finite system, the patient that needs help acutely, or the emergency, is not going to get that in a timely fashion, because the system is actually spending so much time and energy on wasteful activities that don't benefit the patient. So this is what the point that was being made there. Okay, this is the most sciencey bit of my talk, so just bear with me. But it is not rocket science, believe me. You could give this talk to secondary school kids, and they will get it. But there is a bit of mathematics in here. Okay, so just bear with me on this. All right. Okay. So misleading health statistics are also a root cause of medical misinformation that drives certain behaviors and clinical decision making. So there are different ways of presenting a benefit. We can use something called relative risk, or we can use absolute risk, also synonymous with numbers needed to treat, NNT. So let me just explain that. So if you communicate relative risks as opposed to absolute risks, then it can lead lay people and doctors, don't forget doctors as well, to overestimate the benefit of medical interventions. So for example, if we just take a randomized control trial, which is the highest quality level of evidence, albeit industry sponsored, okay, but let's just accept that this results as being gospel truth or close to the truth. If you look at the trial on looking at people with type 2 diabetes and we give them a statin, a cholesterol-lowering drug, which, by the way, just to clarify in your minds, we use statins now. We have been using statins, not about people. A lot of people think it's about lowering cholesterol, but they are actually used to reduce cardiovascular risk irrespective of cholesterol. So just to understand why. But if we look at the trial, and people at type 2 diabetes do have a higher risk of heart disease. So if we look at the trial on use of atorvastatin in people with type 2 diabetes, the results of the trial suggest there is a 48% relative risk reduction in stroke over 4 years. That sounds quite impressive. So imagine a patient comes in, you're the doctor, you see the type 2 diabetic patient, and you think, oh my God, I'm worried he's going to have a heart attack or whatever, I need to reduce his risk. And you, in your mind, think this is a really beneficial intervention. You will say to that patient, and this is what actually happens in reality, there's a 48%, you're 48% less likely to have a stroke in the next 4 years if you take this pill every day religiously. Sounds quite impressive, doesn't it? I mean, pretty impressive, right? But what does it actually mean in absolute terms? So if you look at the actual trial and you look at the people who took the statin versus the dummy pill, okay, and they didn't know what they were taking, that's how you have more rigorous, you can draw more rigorous conclusions about the benefits of an intervention. It reduced the risk of suffering a stroke from 28 into 1,000. So it's over a 4-year period. You take 1,000 people on the dummy pill, and 28 of them had a stroke out of 1,000, right? And then the people that took the statin, it was reduced to 15 in 1,000, okay? Right, does that make sense? So there's 13 people out of 1,000 that have been saved from a stroke because of the statin. And that basically translates, 13 in 1,000 is 1.3%. But another way, which is what I use when I communicate with patients, and it's actually very well validated across the world as a much easier way for patients and doctors to understand those statistics, is 1.3% is 1 in 77. So what I do with my patients, because it's more ethical and honest, is I would say to that patient, if you take this pill religiously every day for the next 4 years, with all the uncertainties about industry-sponsored trials or whatever else, so I always say best case scenario, okay, there's a 1 in 77 chance it will prevent you having a stroke. It's very different, isn't it, from 48% less likely. That also means there's a 76 out of 77 chance it's going to give you no benefit whatsoever. Now, mismatch framing in medical journals, we talked about bias reporting in medical journals earlier as a risk factor for misinformation, also makes the situation worse. So for example, if you have a treatment that reduces the risk of developing disease from 10 to 7 in 1,000, but increases the risk of the disease in terms of the harms from 7 to 10 in 1,000, so exactly the same thing, the journal will report the benefit as a 30% reduction in risk, but the harm of an increase of 0.3%. It's exactly the same thing. So what they've done is they've presented in the conclusions the benefits in relative risk terms and the harms in absolute risk terms. Just think about that. That's just pure marketing. Pure marketing. Non-transparent, dishonest, whatever you want to call it, that's what it is. And one analysis, they did analysis and just took a random selection of articles. They looked at articles in The Lancet, the BMJ, and JAMA. These are very high-impact medical journal articles, and found a third of the articles in the journal published, the so-called gospel truth for doctors to use for clinical decision-making, use mismatch framing. Absolutely extraordinary. So what do we conclude from that? Well, this asymmetry in presentation of data for benefits and harms will bias towards showing greater benefits and diminishing the importance of the harms. One other thing to mention briefly as well, why would they do this? Well, there is a huge bias also with medical journals because they also get a lot of funding from the drug industry. So of course there's the obvious advertising stuff that goes in, but what many people don't know is that say you're a drug company and you produce an article on say a new drug and it's published in the journal, what happens is the drug company can pay hundreds of thousands, sometimes millions, to the medical journal to get reprints of those articles, hard reprints. And then those articles are then used as marketing material by drug reps. So actually, from a financial point of view, if you publish a groundbreaking research, from a drug company, the medical journal is going to get loads of money from the drug company for that. So that's another huge problem that needs to be addressed. Okay, don't just take my word for it. You know, the disruptor Aseem Malhotra. World Health Organization Bulletin 2009, the leading figure in the world on statistical and health literacy, Gerd Gigerenzer, said, and you can look this up, it's online, World Health Organization Bulletin. Didn't make the news, but it's there. It is an ethical imperative that every doctor and patient understand the difference between absolute and relative risks to protect patients against unnecessary anxiety and manipulation. And we quoted that in our piece in the BMJ as well. With the, we said that actually all doctors should. So you might be thinking, hold on, why is this not happening? Well, there's one thing about the knowledge. There's another thing about that knowledge being translated into action. So it's not being taught at the moment consistently in medical schools. It's not part of postgraduate medical training. The default for doctors isn't that they need to learn this, right, this information. So that has to be, that's probably where the barrier is, and that needs to change. Okay, let's just tackle some misperceptions as well, which also drives people's behaviors when it comes to modern medicine, and even policymakers, and everybody actually. So this is a really interesting study that looked at, it was a survey of adults in America who had a secondary degree education, who'd gone through secondary school essentially. So they were educated people, reasonable education. And they asked them, this is only a few years ago, in the last 40 years, we've increased life expectancy, sorry, in the last 150 years plus, we've increased life expectancy in the Western world by about 40 years. So from 1850, the average life expectancy was 40 years old, and let's just say it's around 80 now, okay? So they asked them, how much of modern medicine do you think has contributed to that 40-year increase in life expectancy? And on average, the response, and there was about 800 participants in this particular survey, was 32 years. Most people thought that 80% of that increase in life expectancy, modern medicine was responsible for it, 32 years. What's the truth? It's about 3.5 to 5 years. Modern medicine, that's what it's done for life expectancy. And that's mainly for acute things. You know, cardiovascular disease management in particular, things like emergency care for heart attacks, use of aspirin, you know, antibiotics for infections, of course. You know, that's where most of the big gains have happened in medicine. But actually, so what's the rest of it? What's contributed to the rest of the increase in life expectancy? Well, people have very short memories, or they're not taught about it, or they're just victims of perceptions through marketing, through TV, through magazines, etc. So most of it has actually come from public health interventions underpinned by laws, changes of the law and regulation. Safe drinking water, seat belts in cars, better sanitation, safer working environments, better nutrition in the sense of safe food. We know that although we know food has contributed to chronic disease, it's unlikely that you buy anything in the supermarket is going to give you an acute infection that's going to kill you. So those are the things that have actually been responsible for most of the increase in life expectancy. Okay? Let's take things a bit further back. So this is the Centers of Disease Controlled Health Impact Pyramid. This is about what public health interventions are going to have the biggest impact on society. And this is relevant now because we know society is heading in the wrong direction. Chronic disease is increasing. We know that 80% of the population, certainly in the Western world, in the UK and the US, now have excess body fat that certainly poses a risk to their health, 80%. And the question is, because it's such a major crisis affecting the population, it needs an intervention at population level. So what does this tell us? Well, first of all, counselling and education, of course, it's important. On an individual level, has a much smaller impact compared to, say, changing the context, so making the default choice a healthy choice. So one great example that most of you probably are aware of, where this has had a huge impact, is, for example, is reduction in smoking. So when we had it took 50 years between when the first links between smoking and lung cancer were published in reputable medical journals before we actually had effective regulation that then impacted on smoking reduction. And that was addressing the availability, the affordability, and the acceptability of smoking. But actually, what many, again, you may not know, in fact, I suspect most cardiologists probably it wouldn't come to their mind straight away. The single biggest impact on reduction in death rates from heart disease in the last 3 or 4 decades was taxing of cigarettes. raising the price of cigarettes on a population level, it reduced consumption. So we go back to 1970, about 50% of the population was smoking. We've got that down to 17% now. We can obviously still do a lot better. But all of that reduction happened when we had smoke-free buildings, the public smoking bans, taxing cigarettes. And of course, we need to educate people, 100%. It doesn't work on its own. It needs education as well. So it's important to know that. But let's go a bit further, right? So what's this at the bottom? Largest impact on population health. Socioeconomic factors. What does that actually mean? Okay, so let's just take it a bit further. And it's interesting because I was looking at all of this and I thought, we haven't got the narrative right on this, I think, in terms of helping people understand what's at the root of it. And because we haven't got that narrative right, it isn't then impacting society in a positive way. And by the way, bear with me, this does very much come back to your health, and it does come back to some of the root causes that I think will resonate with you. So what's the actual best way of describing it? We call it the biopsychosocial model. I know you as CNM students and graduates will get this. Okay? So what's actually at the root of this problem, of the socioeconomic drivers of ill health? Essentially, at the very root of it, of course, lifestyle, you can talk about affordability and junk food and all that kind of stuff, but at the very root of it is chronic psychosocial or psychological stress. And this is a great paper published in Nature. One of the authors is a Nobel Prize winner, Elizabeth Blackburn, Too Toxic to Ignore. And their research looks at the impact of stress on telomeres, which are basically part of genes that control the aging process. And it was fascinating. It was fascinating reading this because I could also relate to it with my own mum, and I'll comment on that in a minute. But what it says, for example, is that if you are a mother of, say, a disabled child, say at middle age, they've done research to suggest that the stress associated with that is the equivalent of it ages you about 9 years quicker, right? So the telomere shortening, the most stressed mothers compared to the least stressed, was equivalent to that caused by at least a decade of aging. If you are a victim of severe psychological abuse as a child or sexual abuse, that can knock off 20 years off your life expectancy just from the fact of the epigenetic changes that go on. It doesn't mean we can't do something about it, but it means that those people in particular probably need more intense intervention because you're already starting a process of chronic disease at a very early age. And then, but of course, okay, this sounds great, but is there any biological plausible mechanism behind this? Absolutely. So the biggest cause, so one of the other affiliations I have is with Stanford. There's a metabolic psychiatry unit over there. So there's a very good psychiatrist that's very interested in the impact of nutrition on mental health at Stanford. And we've got an affiliation. I've done some work with them, and we're doing some studies on the use of a ketogenic diet for mental health. But one of the things, I won't go into that now, but one of the things that really made me think a little bit more about this is that if you have severe mental illness, specifically bipolar or schizophrenia, average life expectancy is reduced by 20 years in these people. And of course, lifestyle is a big component of it, but I'm sure a big element is also the psychological stress that's attached to it. So, and the reason I mention that is the main cause of death isn't suicide, it's cardiovascular disease. So the primary cause of death now, the number one cause of death in people with severe mental illness is heart disease or stroke. So what's the mechanism? Well, this is a paper recently published in The Lancet, which essentially did MRI scans, high-tech MRI, looking at the brain, the amygdala in the brain, where they looked at basically, they used correlates of people's levels of subjective stress that they felt and used it with amygdala activity, which is linked to emotion. And what they found, it was very nicely correlated with increasing markers associated with clotting in the blood and inflammation. And actually, we know from other studies, people who are, for example, in low control jobs or low pay, where they feel that they don't have as much value, there are increased levels of a factor in the blood that's involved in clotting called fibrin. So this is well established. So we've got the biological mechanism now, which is really interesting. And then this was a study, it's fascinating. When anyone who would look at this, who wouldn't understand this science, would think, hold on, what's going on here? This is interesting. So UCL, Michael Marmot, who's a guru in this area around the social determinants of health, 1/3 of premature deaths linked to social inequality. Linked to social inequality. What's happening there? How do we explain that? Another great book that I think at some point you should read. It's a brilliant read. It's not boring. It's fascinating, and its wealth of data on it explains it all. So it's called The Inner Level, and these are written by the two sort of researchers in this area. And basically, social inequality, the bigger gap between the rich and the poor, exacerbates stress for everybody. chronic stress, which we're talking about now as a big risk factor for disease. So just to summarize, really, there's a wealth of evidence. So it's a brilliant book with very well referenced. So the inner level now explains how inequality affects us individually, how it alters the way we think, feel, and behave. It sets out the overwhelming evidence that material inequalities have powerful psychological effects. When the gap between the rich and poor increases, so does the tendency to define and value ourselves and others in terms of superiority and inferiority. A deep well of data and analysis is drawn upon to empirically show, for example, that low social status is associated with elevated levels of stress, and how rates of anxiety and depression are intimately related to the inequality which makes that status paramount. So it's called status anxiety. So look at America, for example, look at UK. There's no coincidence that we are actually doing some of the worst in terms of our health outcomes compared to, say, for example, more egalitarian societies in Scandinavia. And this is a factor, which is very interesting to think about. I mean, there's a social justice aspect to it too. And Michael Marmot says this, and I think this is fascinating. A poor quality or stressful job can be more damaging to health than being unemployed. So this is important to understand and remember as well, because you hear politicians talking about, well, we've created all these jobs. And it's like, well, hold on. What kind of jobs are you creating? 0 hours contract jobs? We need to think about that as a society, because we're all interdependent. We're all interdependent. I think the COVID pandemic has drawn that out. We are all dependent on each other. Many people who, we can argue the toss about whether lockdowns were effective or not, and I think most of us can agree there's definite harms with lockdowns. Whether or not there were slight benefits for preventing COVID is debatable. But one thing I think we learned is that we were reliant on so many other people, whether it was just people delivering our groceries, for example, who couldn't actually stay at home. We were reliant on people. We're all interdependent. Whether it's the clothes we buy or the food we eat, we have to think about ourselves. I don't want to get too airy-fairy, but I'm being scientific here. We are one big family. And our own individual health is dependent on others. We don't live in cocoons, and we can't stay quiet when the world around us is burning. And that's where we are right now. Okay, let's go a bit deeper, right? So there's a very nice definition, which I actually would put at the base of that pyramid. And I'm developing something I'm writing about soon to try and change that definition of socioeconomic factors at the base. So it's called the commercial determinants of health. So these are strategies and approaches. It's a really nice definition. I love this. Strategies and approaches adopted by the private sector to promote products and choices that are bad for health, detrimental for health. Okay? And over here you can see you have these big corporations. Okay? We're getting to the big money slide soon. Okay? Big corporations that are global drivers through their business, market, and political practices. They produce unhealthy commodities. Okay? These are products that are harmful to health. By the way, they will often market them as healthy. Right? So think about that. But they're actually harmful to health. And then that drives this industrial epidemic, which affects planetary health, population health, and drives health and social inequalities. And one of the reasons it drives health and social inequalities is a lot of these big corporations. If you look at most of the big corporations around the world, how much are they paying their production workers? Right? How much are they paying the production workers? And what's the gap between the production worker and the CEO? And there's a figure which is floated around which suggests, it's quite shocking. Every time I tell people in the lecture, I'm still shocked by it as well. Because I've spoken to CEOs, and I know various people, and some of them may be my patients or whatever, and I say, just ask a question to you. So what do you think is fair in terms of a production worker in your company, in terms of their earnings compared to your earnings? Like, what should be the difference be, maximum? Should we have a cap on it? Yeah, I think there should be a cap on it, Aseem. Okay, what do you reckon? 5 times, 10 times? Yeah, that sounds about right. Okay. The actual figure? 300 times different. And from an economic point of view, it's actually detrimental, because we find with companies which have a narrower gap between the production worker and the CEO, they do better because the staff feel valued. Their morale is better. So it's, again, something we've got to think about from an economic perspective. Adam Smith is one of the brains behind the so-called free market model. He said that markets function best on relative equality and perfect information. We've got neither. We're being misinformed, driven by big industries with lots of power, and we've got huge inequalities. It's a very bad situation. We can understand what's going on better. Okay, now, it's very difficult for you to read this from there, so I'm just going to talk through it a little bit. But this is how do big corporations exert their power, and how do they drive disease? Okay, so there are 3 dimensions of power. Okay, the first dimension is They have power over decision making and over the political agenda. The second dimension of power is they have power to define issues and potential issues. And the third, power to avert conflict and keep conflict latent. Right? What does that mean? To avert conflict between the interests of the powerful and those over whom power is exerted. The general population and doctors don't know what's happening, and they don't even know that they don't know. Now, what are these vehicles of power? How do they exert this power that then drives all the population problems, right? So political environment, through lobbying, revolving doors, campaign donations, that's more of an issue in America. But certainly I know many politicians. I've got, I can text message at least half of the Labour front bench, so lots of people in the Conservative Party. I have conversations with politicians all the time. And they are subject to lobbying a lot of the time, where they are only getting one half of the information from vested interests, right, who spend lots of money on lobbying and don't know the rest of it, and then they just think that's the truth and they haven't got the whole picture. Remember, the illusion of knowledge is worse than ignorance, right? So that's part of the problem. They've personally told me this, because when I explain stuff to them, they're shocked. They are human like all of us, okay? They're in very positions of power, but they're not getting the information that they need really to make the best decisions for public. And of course, the other things are things like tax avoidance, which is extraordinary. Preference shaping is a good one, right? So corporate foundations in philanthropy, I'll give you an example there. Okay, somebody who's very, very influential at the moment, who you may have heard of, around policies, whether it's WHO or even in this country, or even funding certain parts of our media. Bill Gates. Did you know the Bill and Melinda Gates Foundation heavily invested stocks in the pharmaceutical industry, McDonald's and Coca-Cola? That might be a problem when it comes to unbiased information. Bill Gates is very interested in patents and innovation, that kind of stuff, but he doesn't talk about non-communicable diseases. He doesn't talk about diet or tackling the obesity epidemic. Is that a reason? May well be. Capture of the media. Now, 80% of broadcast print media in the US is owned by about 7 corporations. We have a creeping increase in concern of corporations' influence on the media here. Why is that important? Well, actually, most public opinion, the biggest impact on driver on public opinion is mainstream media. And I found that from conversations at the very highest level, again, of health policymakers. I'll come on to a little story, a little interesting anecdote for you shortly around that. And then they capture the knowledge environment. So you've got science of specification funding medical education, right? And also what they do is the fact that we talked about earlier, it didn't used to be this way. If you go to the 80s and 90s, most university research was publicly funded. Now most of the university research in this country is coming from the drug industry. So those scientists in British institutions, one of the factors is they don't want to bite the hand that feeds them. And even if they won't be proactive and say, hold on a minute, this data is fraudulent or unreliable, they stay silent often, even when they know something's not right. But I would then quote, I would look at it differently. If you're not part of the solution, then you're part of the problem, and there will be no solution. Or even as Mahatma Gandhi, who's one of my inspirations, said, silence becomes cowardice when occasion demands speaking out the whole truth and acting accordingly. But the reason I'm talking about that is it creates that culture, the culture that is anti-human, which is not in our best interest, not for everybody, not for anyone. And then legal environment, so they are protected. Okay, from legal, if they do commit fraud, if there's people even found guilty of fraud within a company, those people are protected because they're doing it in the interest of the company. And then the extra legal environment, something I've also experienced myself, is one of the things is opposition fragmentation. So what they do is, and they do it in very subtle ways, they will target public health advocates. They will say, Aseem Malhotra is promoting junk science, for example. I've had lots of that over the years. When I raise the alarm bell about sugar, I had the sugar industry after me. There's all sorts of stuff going on, right? So I've experienced that. I know that myself. And recently we've seen the issue about the current narrative on COVID, lockdowns, even vaccines, dare I say it. There has been a suppression of free speech. There's only one narrative that's allowed. And of course, one of the ways that they do that, again, is through capturing social media, which I'll come on to, so that people are only getting one version of the truth. So 10 years ago, Gerard Hastings, who's one of the leaders in the tobacco control movement, actually wrote this paper in the BMJ, which is great, called Why Corporate... people were seeing what was happening and how society was going down the wrong direction. And it's called Why Corporate Power is a Public Health Priority. And he says in that, in conclusion, he says, we, not me, we, all of us, as citizens, not consumers, as citizens, need to take the lead in a movement away from a world driven by abeyance to the corporate bottom line and the enrichment of an elite to one that prioritizes physical, mental, social, and planetary well-being. Okay, so let's just give you an example. So I remember Joe Rogan, who you might know on the left, is a very popular podcaster. I think he's the most popular podcast in the world. And on the right, we have John Abramson, Dr. John Abramson from Harvard, very eminent doctor. I've published with him as well. And he's been involved over the years in litigation in many cases with the pharmaceutical industry when fraud has happened. And in this interview with Joe Rogan, I was pretty shocked, but I thought this is something that needs to be shared and thought about a little bit. He talks about the Vioxx scandal. So just to summarize, people may not be aware of this. In the late 90s, early 2000s, a drug was approved and marketed and consumed or taken up by swathes of the population in the US, Europe, called Vioxx. And Vioxx was seen at the time as a better alternative to ibuprofen as an anti-inflammatory painkiller. And it was marketed on the fact that it was as good as ibuprofen, but didn't give you the stomach side effects. Some of you may know if you have ibuprofen, empty stomach and all that kind of stuff, it leads to stomach ulcers and that kind of thing. That's how it was marketed. And in the end, after a few years, it was worked out because there were some things in the original trial in the paper that some clever scientists noticed that suggested it was going to increase heart attacks and strokes. And in the end, they were found guilty of fraud, and it was estimated, and John Abramson talks about this. He says that that it was estimated that probably about 60,000 American men were killed because of Vioxx. Sorry, not men, as in citizen people. 60,000 deaths from heart attack and stroke because of Vioxx. And he said that was the equivalent of the amount of soldiers that died in Vietnam. And it was taken up by about 200 million people, and it caused 60,000 deaths. Okay, fine, it could be a mistake, there's fraud, blah, blah, blah. And in the litigation, emails were exposed, as part of that litigation process. And one email, when the drug was being approved, not later on, when it was around the time it was being approved, was an email that was circulated from the chief scientist of Merck. And it said this: it's a shame that the cardiovascular effect is there, of Vioxx, but the drug will do well, and we will do well. What do you call that kind of behavior? Please feel free to shout out a word. Any?
Criminal.
Criminal? Anything else? Immoral. Yeah? Okay. So a forensic psychologist called Dr. Robert Hare, in a book called The Corporation, in a documentary that came out again in the early 2000s, he's actually the forensic psychologist behind the actual definition of psychopath. And this isn't a joke, actually. And in that book, he actually says that the legal, and this is not about individuals, by the way, but the legal entity that is the corporation, the big, powerful corporations, let me stress that, not all corporations, but the really big, powerful corporations, behaves in a way that is akin to being a psychopath. Okay? So callous unconcern for the feelings of others, reckless disregard for the safety of others, deceitfulness, repeated lying and conning others for profit, incapacity to experience guilt. So he says actually many of these big corporations. Now, I want to make it clear, this isn't about individuals. I think what happens is the system encourages good people to do bad things. A few years ago, was asked to debate in a Cambridge Union debate about too many pills, and the motion was, wait for it, we need more drugs. We need more people to be taking more drugs. And the motion was put forward by AstraZeneca. Okay? And I was on the other side of the debate, and I directly debated with the CEO of AstraZeneca, who we had, before the debate, there was a dinner organized by them, very nice guy. I'm sure he's great with his family and all that kind of stuff, so I'm not criticizing him. I mean, the other thing I must mention as well, the debate went quite well, although most of the audience that turned up for the vote were employees of AstraZeneca. But I think what was interesting is before the debate, they asked the audience, what are your thoughts straight away? Do we need more pills? Yes, no. But what we did is we shifted the debate. So people that come in saying we need more pills said, and in fact, one guy got up and said, for the first time I've come to a talk and I've actually changed my mind because of the debate. So that's good. But anyway, the point I'm making is it's not about him. I think it's about the system. The other thing I must mention is after the debate, he actually he sent me a book to sign on the history of the Cambridge Union, so he does know where I live. And that's so yeah, I've got to be careful there. Anyway, but on a serious note, this is really, so should we start talking about the psychopathic determinants of health? Maybe that should be in the socioeconomic. So I think if we don't talk about that, certainly it's anti-human in the way that corporations conduct themselves. But I would say that probably we need to change the definition to, psycho-socio, economic, political, because politicians control regulations and laws, and the commercial determinants of health at the bottom. Now, sorry, I've given something away there. We talk about social media. I talked about, what was the company that was involved in the Vioxx Scandal? Remember the name? Merck. Okay, so guess who Facebook have partnered with to decide on what social media, what's misinformation around the vaccine and drugs? Facebook and Merck commit $40 million for Alliance for Advancing Health Online, right? Facebook and Merck have committed $40 million to a multi-year initiative, half and half, 20 each, to a multi-year initiative of establishing the Alliance for Advancing Health Online. The initiative will initially focus on addressing vaccine hesitancy and vaccine equity amongst undeserved communities. How lovely. Okay. Briefly about the NHS. I'm a big NHS campaigner. I think one thing that, again, in terms of the narrative, people need to understand that privatized healthcare systems don't do as well as public ones. Okay? There's a wealth of data around the world. America spends probably the most than any other country on healthcare, but has one of the worst healthcare outcomes. And the reason for that, and this paper in the BMJ talks about it, evidence shows that major non-public sector provision impedes monitoring of quality and effectiveness and leads to inequity and exploitation with suboptimal care for both rich and poor. So it's actually worse for both rich and poor, because rich people get exploited by spending lots of money on unnecessary investigations or tests, and poor people in certainly privatized systems don't get access to care. And the thing about publicly funded entities compared to private is there's a much greater emphasis on quality and certain standards. When you've got profit-making businesses in health, often what happens is they want to pay their workers the least amount of money, so you get a decline in quality and costs go up as well for people, right? So overall, in general, the evidence is pretty clear on this. I'm happy to discuss it with people, but in general, in a healthcare system, publicly funded. So don't be deceived, because I think one of the problems that's going on right now, politically motivated, vested interests, is, okay, NHS is crumbling because the NHS itself, that model's failed. It hasn't failed. What's going on within the NHS as well? One is, over time, there's been creeping privatization. And the other side of it is, as well, is we've got a corporate culture within the NHS. So Aneurin Bevan, who was the politician that really was the person that pushed for universal healthcare, actually said what we should be focusing on in the NHS is it's not about access to healthcare, it's about universalizing the best health for all. That's what we should be focusing on. And when you bring private provision in there, you have more cost and you have less quality. More cost, less quality. More cost, less quality. That's all you need to know. That affects everybody. And then I didn't imagine my worst nightmare was going to come true. So again, I lost both my parents prematurely in the last few years. And I wrote articles about them. One featured on the front page of the Iron newspaper a few years ago about my mum. And they headlined it, based upon my article, as NHS Cuts Killed My Mother. And what really led to her death was, one, these things are multifactorial. One is the wider determinants was around the fact that she was probably addicted to ultra-processed food. She had issues with her weight over the years. She got high blood pressure. Then she suffered a stroke, which she survived a brain bleed, and then I taught her to swim after that, and and she got a lot better. And then she got crippled with very bad rheumatoid arthritis. And I think, to be honest, it's something that's occurred to me recently. One of the things I think was a factor, obviously her lifestyle wasn't the best, because she died at 68, very young, was the fact that I had an older brother that died when I was 11, and he actually had Down syndrome, quite severe. And I just thought back and I thought, God, how was that for my mum and dad to have their oldest child that needed, and I think maybe epigenetics, who knows, it may have caused a lot, may have started a process for her. That doesn't mean lifestyle couldn't have had an impact. But anyway, then she got admitted to hospital. In the last year of her life, it was awful. She had a lot of chronic pain. My dad was a carer. She was deteriorating physically. She was using a Zimmer frame, and she's only in her late 60s. She was a GP for many years. She had to take early retirement. And in the last year before she died, she was admitted 3 times with spontaneous osteoporotic fractures of her pubic rami, just in pain, literally just because she was so frail. And then she got an infection in her spine. And the reason I wrote about this NHS Cuts Killed My Mother, which was a headline there, it wasn't the fact that she was so ill and this was a chronic issue that developed over time. She was in hospital, and we thought she was getting better. And then she suffered a heart attack, probably because of the stress on her system. And because the system was so busy, because of the things we talked about hasn't been tackled. Part of it is because of lack of staff, but also is because we haven't tackled prevention, right? And waste, right? The system's so busy. The heart attack was missed by the team. I diagnosed it down in London. I kept going back to see her because one of the physicians did an echo on her and said, Aseem, what's with this echo? And I said, hold on a minute, she had a heart attack. And it was missed for 9 days. Then, around the time it was missed, she then went into what we call crashing pulmonary edema. She went into heart failure. And my poor dad, who was a doctor and a very well-known doctor in that community there, the former actually chair of the trust of that hospital. So it's not that, we knew all the doctors that were probably, because we knew them, being a little bit more attentive than normal. He sat by a bedside with his best mate, who's also a doctor, witnessing her for 2 hours not being treated because the hospital was too busy for pulmonary edema. So she was effectively like drowning. And it was awful. And these are the sorts of things where very quickly you can relieve suffering by giving them a diuretic, and you can get rid of the fluid, and people feel like they're breathing normally again. Awful. So I talked about the fact that the system failure led to the fact that she may not have died any later, but she suffered unnecessarily. And then my father, I got a phone call from him, and my dad was a very fit and active guy. He was honorary vice president of the BMA, very politically active, very physically active, got a scholarship into medical school because of being a sportsman. So it was a very shocking situation that happened with him. 73, July the 26th, coming up to his anniversary, and he called me, and I was down in London. And we'd always joke a little bit because, I'll be honest, he was a bit of a hypochondriac, and so am I. And he's a GP, so I was all calling him about some funny rash or whatever else I've got, and he'd say it's nothing to worry about, and then he'd call me about his stuff, and I'd say there's nothing to worry about. But this time when he called me, he had chest pain and it sounded cardiac, and I said, Dad, you need to call an ambulance. And he was a bit reluctant. He said, well, I'll call a neighbour. I said, no, you need to call an ambulance, because even if there's no heart attack, you need to stay in, be monitored, etc., and see what's going on, because the pain it sounded cardiac. And then I went for a shower, ready to get on the train to jump up to Manchester, come out of the shower, call him back, no answer. Call him back, no answer. Then one of his neighbours, who's a doctor, answered the phone, quite hysterical, understandably. He said, Aseem, your dad's had a cardiac arrest, we're doing CPR on him. Stay on the line. I said, listen, don't worry. You've witnessed it. This is good. The ambulance is supposed to get there within 10 minutes, because I've audited this stuff. I did lots of work on ambulance and cardiac arrest and stuff in the past. So I was like, don't worry, it's fine. This is actually good. He's lucky. You were there when he had the cardiac arrest. He'll be fine. Waited. Ambulance didn't show for 30 minutes. Then by the time the ambulance came, they FaceTimed me to see while they put the cardiac monitor on him. And normally you can shock people very quickly. Within 10 minutes you have a cardiac arrest. Most of the time, if it's a witness CPR, you will get them back. It was a flat line. There was nothing to shock, and I just had to stop. And then I was at the time, I just didn't understand what was happening, right? Obviously it's a big shock to lose my father, who was also my best mate. But there was like, well, hold on, what happened here? Is this just an odd mistake, or is there something else going on? So I asked for an investigation to be done, because why did it take 30 minutes? And basically what happened was, in the interim, I won't name this person, but a very, very senior person in NHS England, who was a nurse, former nurse, very senior nurse, who knew my dad. She was in tears. She called me up, and she said, Dad she knew, wonderful man, all this kind of stuff. I'm really, really sorry, Aseem. I have to tell you something. I said, what is it? She said, before your dad had a cardiac arrest for several weeks, both NHS England and the Department of Health, including Sajid Javid, knew across the country that ambulances were not getting to patients in time for acute care. And he said that my own husband, 3 weeks earlier, came home from playing football with chest pain. And this is one of the most senior nurses in NHS England. I didn't even call 999 because I knew it wasn't going to come in time. I put him in the car, drove down the hard shoulder to the local A&E, and they diagnosed an acute heart attack and they treated him. And I just thought, wow, this would have changed his outcome. We wouldn't have asked him to call an ambulance. Somebody would have, it was about 45, he would have taken him to hospital, 5 minutes, 10 minutes away, would have defibrillated him, would have been fine. So I did an investigation. The Eye exposed it, and then it became a big BBC story, and I was probably the first person to highlight it. And I did it because I felt it was my duty and responsibility as a doctor. But just to tell you about the cultural problems in the NHS, I texted somebody who's one of the good guys who I trust, who's a very eminent cardiologist in a leadership role in London. And I said, listen, I'm emotional here. I'm a cardiologist, but this is my dad. First of all, do you agree with the circumstances I put to you, that he would have likely survived if the ambulance would have come on time? And he said, yes. And I said, well, listen, this is what's happening. This is what I found out, and I'm going to write about it, and I'm working with a journalist. And you know what he texted me back? He said, Aseem, I wouldn't if I were you. You don't want to make yourself more enemies. So he was happy. He said, prefer don't expose it. But isn't that our duty? And I replied back, but isn't it our duty to patients and the public? He didn't reply. And then eventually it was found out, again, a private provider was involved. Of course, the ambulance delay was a big issue anyway, but there was more mistakes that were committed that should have been, and it was actually a private provider that was involved down the 999 call that had actually called the ambulance late, thought she'd called the ambulance and didn't, and I'm not blaming her, but basically, you know, this is when you get staff that aren't as qualified, don't fully know what they're doing sometimes, on low pay. You know, this is all part of the problem, and that was then exposed in an article. Okay, so where do we move from here? I've pointed out lots of problems. What are the solutions? I talk about real evidence-based medicine. So again, just coming back to that definition, what is evidence-based medicine? It's the application of individual clinical expertise and better level evidence, and then take into consideration individual patient preferences and values. This is crucial. We need to keep thinking about this again, ethical. It makes the ethical care of the patient the top priority. And then, you know, shares decision with patients through meaningful conversations. And then what needs to be done, and of course it also says applies these principles at community level for evidence-based public health. So what are my thoughts? I'm building on what other people have done as well, so it's not just me, and I've adapted it. Although the drug industry plays an important role in developing new drugs, they should play no role in testing them. And they certainly shouldn't be allowed to hold on to the data. What they do is they often just give summaries to the regulator. The raw data is usually tens and thousands of pages long. And historically, when we've got access to the raw data, for example, Tamiflu was a drug that we spent £500 million on in the UK stockpiling for the next flu pandemic. And it was a drug that was produced by a company, Roche. And when independent researchers, after many years, had noticed that it was marketed as reducing severe outcomes, they found it was no better than paracetamol and had some serious adverse effects. When they were accessing the raw data, they knew what was missing, the whole data wasn't there, that kind of stuff. So no, this is nonsensical. I don't think anybody here, in fact, any member of the public, if I told them, would you support the drug industry doing their own trials and then holding on to the data and nobody can see it? Nobody. This is not democratic. It's not good for health, clearly. We've seen what they've just done, those policies. We've seen what it's done to society. It's time to change it. All results of all trials that involve humans must be made publicly available. Regulators such as the FDA and the MHRA must be publicly funded and not receive any money from the pharmaceutical industry. So last week, the BMJ published an investigation. I don't know if you saw this. I talked about it on GB News. That basically, and I was shocked by this. So 86% of the funding for the medical regulator in this country, the MHRA, comes from the drug industry. And it didn't used to be like, it used to be publicly funded. So it's a conflict of interest, isn't it? And what's also interesting isn't just about funding those, funding the regulator. There's a revolving door situation that goes on. I don't want to name anybody, but let's just say in that BMJ paper you can read about it. Somebody very senior who spent many years as a lead person in the MHRA, when they left their job, then has got a very lucrative job with the drug industry, advising the drug industry. So they're already thinking ahead. If you're in that role, it's human nature, but think about it. If you're friendly to industry, you approve more of their drugs, then when you leave your job, when you come to the end of your term, oh, here's a nice job for you. Independent researchers must increasingly shape the production, synthesis, and dissemination of high quality. So we need independent analysis of all of these trials to work out what's reliable, what isn't. What's the NNT? What's the numbers needed to treat? We can break that down. And I think with a certain product, at the moment that's being used widely, I think that we need a bit of that information. And I think the results of those, when that comes out, I think will surprise, maybe not surprise you guys, but will surprise a lot of people in terms of the effectiveness of it. Medical education should not be funded or sponsored by the pharmaceutical industry. I've honestly stopped going to cardiology conferences where they're sponsored by the drug industry because I just can't trust the information, unfortunately, to be unbiased. And that's a problem. And then patients and the public must demand better evidence, better presented, using absolute and not relative risk. It's really important. And better explained and applied in a more personalized way. Right, so how do we change everything? Okay, we're getting towards the end of the talk. We're going. So how do we change everything? So there's a really nice approach framework structure developed in Thailand called the triangle that moves the mountain. Okay, so how do we make these big changes? We've got to move a mountain. So how do we do it? Well, we need to make sure we create the right knowledge. The knowledge has to be concrete and clear. what the problems are, what the solutions are. Then you have the social movement, okay, so that knowledge is then disseminated for the social movement, and then that needs political involvement, because ultimately the politicians we have our gripes and concerns about trust in politicians, but ultimately they're the lawmakers, and they're the ones that actually have the power to introduce. Historically, we look at public health interventions that came from government. Two of the main primary purposes of government, let's not forget this, to protect the population from external aggressors and to protect the population from disease. It is their responsibility, so we need to make sure that they are accountable for that, okay? And then how do we do it? Well, I won't bore you with this, but over the years I've built this just by writing. Don't underestimate the power of your speech, the power of the truth, okay? Most people often feel they don't know what to say, they don't know how to say it, they're afraid to speak up, but ultimately the truth, the sword of truth is more powerful than anything. It's what we all want. And we can make our individual decisions, but we want the full information. So in my, how have I managed as an activist to become a lead campaigner on sugar reduction or transparency in medicine, or whether it's about statins, for example. So through publications, I've done that. Obviously through lectures to doctors, public, to Parliament. I've spoken to European Parliament, British Parliament. I have access. Conversations are really important with senior people. Understand where they're coming from. Speak to them. Try and increase their knowledge base. Make them act upon these injustices. And then broadcast media, of course, is very, very important. And social media as well. And of course, relationships are very important. Maintaining and strengthening alliances. And of course, persistence and dedication. This is not easy stuff. It is not easy to do. But you have to just keep trying. You have to be patient, and you just got to keep chipping away. And just a few examples of things that I've done. So I managed to make BMA policy that we ban junk food sale in hospitals. It hasn't been implemented yet because ultimately the chief executives have to sever contracts with a lot of these companies for it. But at least the medical establishment, I played a role in at least getting them all on board, saying, yeah, I don't think we should be selling junk food in hospitals. It's not really setting a good example. And there is data that shows actually, and it's deliberately by these companies, they knew. What happens is, they did a study in America in pediatric institutions, and if you visited a pediatric institution in America where they were selling junk food, you were 4 times more likely as a visitor to purchase junk food when you left the hospital than people who hadn't visited the hospital in the first place. So there was a legitimacy thing. It's acceptable. It's all about calories or burn it off and all that nonsense, right? That's it. And then one of the other things I did was after I wrote a piece in the Observer newspaper, I was asked to go on BBC News, like, bloody hell, I've got a few grey hairs since then. It was 10 years ago. But I was the angry cardiologist that said, in the middle of the Olympics, why are the main sponsors McDonald's, Coca-Cola, Heineken, and Cadbury's? And then, my own investigation on sugar, I literally myself found out over a period of about 2 years, I started looking at this, that very specifically in Europe, the guidelines on consumption of sugar were suggesting or telling us that we should be consuming 22.5 teaspoons of sugar a day as our guideline daily amount. Yeah, it's European. So I went to the roots and investigated it all and found out ultimately the sugar industry were controlling it. And then I wrote this piece with all the up-to-date evidence, and it was press released, and I was on BBC Breakfast. That was in the good old days when Bill Turnbull and Susanna Reid were presenting BBC Breakfast. And it was interesting at the end of it, because I said, listen, Science and Sugar says this many teaspoons is maximum for health, but we're being told to eat 3 or 4 times that much. What's going on here? And then Bill Turnbull at the end, who said Aseem afterwards, it was a great interview, he said, it's very telling though, and he said this to the camera, he said, we did ask 10 different companies or organizations associated with carbonated beverages, supermarkets, sugar manufacturers, etc., to discuss this with Dr. Malhotra. All of them were unavailable. So, other people contacted me, we launched action on sugar, and that became a huge, and we got, whether it was left-wing or right-wing newspapers or whatever on board, and obviously then we end up getting a sugary drinks tax, which was great. It's a good start. We need to do a lot more, obviously choosing wisely. The other thing is coming back to evidence-based medicine triad. So in my own clinical experience, I put this into practice with patients, and one of the most interesting patients I've ever managed is a guy called Tony Royal. He's been public about this. I'm not breaching any confidentiality here. And Tony was a guy that was a former Virgin Atlantic International airline pilot, very, very smart guy. And then he suffered a heart attack in his 50s despite running marathons, and he couldn't, and then he was put on a cocktail of drugs and had a stent put in. And then basically he came to me and he said I saw him privately initially, and he came to me and said, by the way, he basically got side effects from his drugs. He's figured it out himself. He was a maths and physics teacher, started reading the research and thought, oh my God, this is a bit rubbish in terms of benefits, but then massively changed his lifestyle, went ketogenic diet, and then started breaking his own records in ultramarathons, and he came to see me and talk about it. And then this is actually quite recently, I've been in touch with Tony still, and he decided, I'm not saying every patient should do this, but through informed decision making, a heart attack patient with a heart stent decided over a number of years to come off all his meds, and his cholesterol profile is outstanding, and he's breaking his own records now. which is just brilliant. So just to show what can be achieved, right? And if you look about this on a bigger scale, we take everyone in consideration, you know, and then this was press released, and we got a bit of, you know, it was a bit of some headlines on it, which was great. I love that one. Ditch pills to beat heart disease, and ditch the statins and eat your way back into good health, right? Great message. And then more recently, again, I had to chip away for quite some time at this, but raise awareness that the link between COVID and adverse outcomes was strongly linked to excess body fat. And then Matt Hancock contacted me after I'd written a few articles, and I was on Good Morning Britain, and I think I was the first guy to suggest that Boris probably got sick and got hospitalized because of his weight. And then Matt asked me for advice on all of this. Of course, even them knowing, I mean, Matt has admitted, he didn't say specifically my book, I gave him my book, but he then later on said he lost 2 stones from basically going low carb after he got my book. So, you know, these people are also victims of the system, yeah, as well. And we've got to understand the system failure and how we address it, I'll come on to in a minute. Okay, so let's move on. And then I'm briefly going to talk about NHS vaccine mandate. So evidence changed and over since when the vaccine was rolled out. And I think we got to a situation, certainly towards the end of last year, where it was clear that the vaccine wasn't preventing infection, preventing serious illness and death, of course, to some degree, although we don't know the absolute terms yet, but let's just presume that's true. But the key thing was it wasn't protecting people from infection, and there was a lot of natural immunity. And then this NHS staff vaccine mandate, which didn't come from the medical establishment, came from the politicians. And I remember I did everything I could to lobby on this, I'll be honest with you. I was on BBC, I was on Sky, I was on LBC, GB News, saying that it is unscientific, unethical, and also impractical, because it was estimated, I think by that stage, I think about 70,000 NHS staff had decided they weren't going to take the vaccine. They were about to lose their jobs. I had so many people calling me, they were in tears. And I was privately advocating, I won't say through who, but I got message through to Sajid Javid. And I also was publicly speaking out about this. And this is just a text message from somebody I don't know. She's a cardiac sonographer. She didn't mind me sharing this with you. And she was really upset. And she said, just a heads up, the mandate has been agreed by the House of Lords, gutted. Thank you for fighting for us NHS staff. And I said, this doesn't change anything, can still be overturned, hang in there. Because I knew, just you know, dig your heels in. And eventually we got it overturned. And I was, you know, to be honest, of all the things I've done, to some degree, this is in some ways given me the most satisfaction, because to help contribute to save 70,000 NHS jobs was very satisfying. And also, it's about integrity, right? So those people, they are heroes for standing up for autonomy and justice. I just want to say that, honestly, because the science was on their side by that stage. Okay, and then I got a very nice message after that from this person. Okay, so what do we do? How do we change things? So lessons in public health advocacy. Simon Chapman, single most influential figure in tobacco control in Australia, talks about his 38-year career in public health advocacy. How did he win in the tobacco wars? And he talks about, first of all, this is really important, media attention on a public health issue is often more effective than private advocacy in winning policy change. Advocacy must be evidence-based, clear and concrete. Speak up publicly, study the media, and be able to speak out at all times. Use killer attention-grabbing facts, but place them in the context of a value system. Care about what you're advocating for. Values are so important. Use real people to illustrate your message. Case studies. We're all emotional beings. We can hear lectures on sciencey stuff. It's more interesting when there's a case study, when there's a human element involved, because we are primarily emotional beings. Use social media, be patient, and grow a rhinoceros hide. And he says, grow a rhinoceros hide, and I can definitely relate to this. He says, unless you are an advocate for an utterly uncontroversial policy, as soon as your work threatens an industry or an ideological cabal, you will be attacked, sometimes unrelentingly and viciously. Right? And myself and other people have had, maybe that's a book or whatever for another time, but anyway. Okay, so what do we do? We're almost finishing. So how do we change all of this? So I think we need to refocus, think differently about how do we tackle the big anti-human, to put it politely, entity that is the big corporation that is driving a lot of this chronic disease, deteriorating mental, physical health, social inequalities. So field of public health needs to refocus research programs, reframe our way of thinking about and acting towards corporations. This isn't about individual responsibility. This is about the wider social determinants of health primarily. Of course, individual responsibility has a role, but we're not going to make much impact if we just focus on individual responsibility, because those wider drivers of what's affecting our health. And then disconnect our research programs. And then, of course, we have to think about how do we redesign the corporations. We need to think about ethics and spirituality. I love this quote from the late Robert Kennedy, who was assassinated. And he said even then, he said, the gross national product does not allow for the health of our children, the quality of their education, or the joy of their play. It does not include the beauty of our poetry or the strength of our marriages, the intelligence of our public debate or the integrity of our public officials. It measures neither our wit nor our courage, neither our wisdom nor our learning, neither our compassion nor our devotion to our country. It measures everything, in short, except that which makes life worthwhile. And, you know, ancient wisdom teaches us to lead the good and happy life, we have to act virtuously. You know, knowledge without action is vanity. Action without knowledge is insanity, right? But wisdom without courage is a waste of time, it's fruitless. And of all these virtues, Maya Angelou says, courage is the most important of all the virtues because without courage, you can't practice any other virtue consistently. So we need more of that amongst us. As individuals, we are more vulnerable. But as a group, the real power is actually with the citizens. We need to regain that power for the purposes of societal health. Okay? And then Abraham Lincoln, just come back to where we're going, what we need to focus on now, also predicted this. I see in the near future a crisis approaching that unnerves me and causes me to tremble for the safety of my country. Corporations have been enthroned, and an era of corruption in high places will follow, and the money power of the country will endeavor to prolong its reign by working upon the prejudices of the people until all the wealth is aggregated in a few hands and the republic is destroyed. Okay, so it's time to rise up against this organization of misery. As Harvey Milk said, rights are only won by those who make their voices heard. Hope is never silent. And to finish, I think one thing we all probably would agree with, Mahatma Gandhi said, it is health that is the real wealth and not pieces of gold and silver. Thank you very much.